A very big hello to all my dear students. Welcome to your favorite channel of You and I with Dr. Ruchi Rai. So today in the T2O series, we are here with the spot diagnosis. So today I'm going to discuss a few interesting slides I have randomly selected and we'll try to diagnose it, right? So let's start. Okay, here comes our first slide. So what are you looking at? What I can see is there's a nystagmus which is being indicated in this animated slide where one eye is up, one eye is down. When the eye is up, it intorts. When it is down, it extorts. What are we talking about? Yes, so here the answer will be seesaw nystagmus. So here we will say it is seesaw nystagmus. That's our first slide. So seesaw nystagmus viewpoints, it is mainly seen in chiasmal lesions, that is bitemporal hemianopias. Let's remember that. Come to the second slide. Okay, so now what you are looking at? I can see an iris through the slit lamp examination. I'm looking at the iris. What I see, what are these red areas? These are defects of the pigment epithelium of the iris. The pigment epithelium in the iris is just at the back of the iris, correct? So when there is a defect of dispersion, more light is passing through that area. We are looking at trans-illumination defects. So we are looking at trans-illumination defects. So trans-illumination defects will be seen in when the epithelium is gone from that place. Which condition? So this we see in pigment dispersion syndrome. So you will answer pigment dispersion syndrome. Everybody remembers pigment dispersion? It can lead to secondary open angle glaucoma. You have learned pigment dispersion syndromes in secondary glaucoma. So it causes secondary open angle glaucoma. Of course, this is the normal pupil with the normal fundus glow that you are looking at. Okay, next one. What are you looking at now? So I've just taken this clip. Have a look at it and let me know what are we looking at. So the background stimulus is moving and the eye which is looking at the stimulus is also showing movement. Right? Falling movement, refixing. Falling movement, refixing. So what is the slow falling movement known as? Pursuit. And refix is called saccadic. Yes, you are looking at optokinetic nystagmus. So here the answer is optokinetic nystagmus. OKN. In short, we note it as OKN. So this optokinetic nystagmus, I hope you all are very clear, is not pathological but a physiological nystagmus. It consists of pursuit movements and saccadic. Pursuit, as I just said, slow following movements, and saccadic is your abrupt movement to refix the object on the fovea. Okay, we come to the next slide. Let's see now what we have in store. So what are we now looking at? Can you see when the child is sucking the milk, the lid is moving up and down. The right eye upper lid is moving up and down, right? So movement of the jaw causing movement of the lid. What is this? Marcus gun jaw winking phenomenon. Yes. So here our answer would be Marcus gun jaw winking phenomenon. Marcus gun jaw winking phenomenon means movement of the lateral pterygoid is connected with the LPS movement. That means LPS applied by third nerve and lateral pterygoid fifth nerve. So third nerve and fifth nerve. This is the aberrant connection which is causing Marcus gun jaw winking. What is the other name? We will say it is thin kinetic ptosis. We call it thin kinetic ptosis. Okay, we come to the next slide. Now let's see what we have to see. What are we looking at? When you close one eye, what happens? What do you see in the other eye? Can you see the nystagmus in the other eye? Now close the right eye. See, there is movement in the left eye as well. Though it's mild, but it is there. Right? Again, when you are occluding the left eye, the right eye starts showing nystagmus. This is what is called latent nystagmus, which is only manifested when you break the fusion reflex or when you cover one eye. Okay, so here our diagnosis would be latent nystagmus. और कहाँ पढ़ा था? Where else did you learn latent nystagmus? It is also a feature of infantile esotropia. Come to the next one. Okay, let's see what we have in store now. So what are you looking at? Can you notice the tremulousness in the iris here? Yeah, we are looking at here the diagnosis is iridodonesis. Iridodonesis. It will happen when the support on the iris is lost. Normally there is a support on the iris by the lens. When that is lost, you get iridodonesis. So iridodonesis mainly, what can be the cause when there is no lens? That is aphakia. Or support could also be lost in case of ophthalmos. When there is too much enlargement of the eyeball, the distance between iris and lens is too much. Hai na? So you will say ophthalmos. These can be the causes. Let's talk about the next slide. What are you looking at? Can you notice number one, small horizontal length of the lids? Blepharophimosis, number one. Number two, we can see this red arrow is showing us ptosis. Number three, telecanthus, more distance between two medial canthus. Though interpupillary distance is normal, then you call it telecanthus. Isn't it? What else we see is a fold of skin. If you look here, this is the fold of skin from the lower lid. Because it's arising from the lower lid on the medial canthus, normally extra fold of skin is from the upper lid. Here I can see that extra fold of skin from the lower lid. So we call it epicanthus inversus. This is called epicanthus inversus. So one is epicanthus inversus. One finding we just learned is blepharophimosis, that is shortening, horizontal shortening of the lids. Then we learned about ptosis, right? Then we learned about telecanthus, increased distance. What else? One more feature is congenital ectropion of the lower lid. Congenital ectropion, yes. So what is the diagnosis? In a spot diagnosis, what will you say? What are you looking at? We are looking at blepharophimosis syndrome. So your answer should be blepharophimosis syndrome. Okay? Yeah. Okay, we come to the next slide. What do we have in store? This one I think is very simple for you all. It's an important slide, so I thought let's include it. What are you looking at? What will be the diagnosis? Cherry red spot. So when you say cherry red spot, very quickly, what are the causes? So learn with me, blunt trauma, that is Berlin's edema. What is other name of Berlin's edema? Commotio retini. Dusra batao? CRA, central retinal artery occlusion. And third, I would like you to learn it as depositions. What are depositions? Sphingolipidosis, gangliosidosis, all these are different types of depositions. Tay-Sachs disease, Niemann-Pick. And please, this is a debatable topic, but Gauchers you do get cherry red spot. We'll always learn like this, okay? Yeah. Come to the next one. So what are you looking at here? I can see a linear ulcer and I can see what do you see? Knob dens. We are talking about dendritic ulcer. And dendritic ulcer, if this is the answer, this is the diagnosis, dendritic ulcer is a feature of herpes simplex keratitis, not zoster. In zoster, you get pseudodendrites, not dendrites. Please be very, very clear. Correct? ठीक है? Okay. So that was about dendritic ulcer. What else? What are the other things around dendritic which cause confusion? If they ask you this question, what is the pathognomic feature of viral keratitis? Very common mistake, you all answer dendritic. No. Pathognomic feature of viral keratitis, you should answer decreased corneal sensation. As I told you, dendritic ulcer is not a feature of zoster. And what are the other causes of decreased corneal sensation? It could be leprosy, it could be diabetes, it could be just section of the trigeminal nerve, and so on. Another thing which is asked around dendritic is steroids are totally contraindicated in a dendritic ulcer. If you by mistake give steroid, it is going to lead to geographical ulcer and corneal perforation. So keep this in mind. And anyway, you should be very, very clear that steroids are contraindicated in any infective epithelial involvement. I'm talking about epithelial involvement, that is ulcerate. Okay, so that was dendritic. We come to the last slide. What are we looking at? Here our diagnosis will be leukocoria, left eye. Of course, it should always mention the eye also, it's always good. So leukocoria, left eye. Leuco is white, chorea is pupil. Right? So leukocoria, you should be very, very quickly, what are the different causes of leukocoria? It could be congenital. So think like this logically. What can be the causes where the pupil is shining white? Some causes where there is central, which can be responsible for pupil looking white. So it could be congenital cataract, cyclitic membranes. It could be central retinal detachments, choroiditis. In children, central choroiditis is due to toxocariasis. Okay, what else? Oh, it could be just retinal diseases like ROP. Then it could be Coats disease, which can also later lead to scarring and RDs. What else? It could also be retinal dysplasias. And of course, let's not forget coloboma, central coloboma, where a part is not embryologically formed and the background sclera is shining white. Of course, retinoblastoma is something apart from retinoblastoma. I'm giving you all these reasons of leukocoria. We have to always first think about retinoblastoma and, of course, screen the child for that immediately, isn't it? Yeah. And all the causes of leukocoria, leaving aside retinoblastoma, I hope you know, is collectively known as pseudogliomas. That is called pseudogliomas. Okay, so that was about leukocoria. And yes, so that was the last slide. So this is all for today. A very quick session. So whatever if you feel this topic you don't know in detail, you can just study nicely and you can ask me and DM me. Right. So let me end the session with reminding you a thought for the day, which I keep reminding you so many times. So hope you, as I requested, you all have noted down in front of your study table that still I'm not discouraged. So I want all of you to never give up till you succeed. Never, never give up till you succeed. Keep moving, keep moving, keep moving. Thank you so much. Stay blessed and keep smiling.